training for the fellows. And I just want to say that earlier Karen informed me that we had quite a number of interest in this particular talk. More than 32 fellows registered so far, and I believe more has since then registered. And they're from, anywhere in sub-Saharan Africa, and I can tell you some from Ghana, from Kenya, from Mozambique, Nigeria, South Africa, Sudan, and Uganda. We obviously want to say thank you to Gastro Foundation for hosting this GECO meeting in association with the Project ECHO of the University of New Mexico. And our speaker of today is Joseph Adebiyi. He is at Charlotte Maxeke, and originally he is from Nigeria. He will talk on GERD, NERD, and functional dyspepsia. Over to you, David. Over to you, Joseph.
Thank you, Dr. Fredericks. I'm not sure, I just want to confirm if you can hear me.
Yes, we can hear you well. You can proceed.
Thank you so much. So we were talking basically about gastroesophageal reflux disease, and then we'll extend the talk to non-erosive gastroesophageal disease, as well as functional heartburn. That would be my outline. So gastroesophageal reflux generally is it's a normal physiologic process. So basically the refluxing of gastric contents from the stomach into the esophagus, occurs several times a day. So it's basically a physiologic process, and everyone, goes through this process every day. However, this necessarily is not a disease in itself, and then becomes a problem when it then produces troublesome symptoms of heartburn and acid reflux. And basically it's due to the failure of the normal anti-reflux barrier to protect against frequent and abnormal amounts of reflux materials. So the 2006 Montreal Consensus tried to, put together, sort of a basic non-cumbersome definition of GERD. And it defined it as the condition that develops when the reflux of stomach contents into the esophagus produces troublesome symptoms with or without complications. And so this essentially utilizes pathological, physiological, and symptomatologic information to develop a sort of a complex, to highlight the complex relationships that occur between reflux and symptoms. So it does provide a symptom-based approach to the treatment of GERD, and this then goes on without the need for complex, expensive, and cumbersome investigations. However, the objective definition or diagnosis of GERD is essentially characterized by mucosal injury that you would pick up on endoscopy. So this would be characterized by LA grades C and D. And if you do pick up Barrett's esophagus, as well as the evidence of peptic stricture on endoscopy, then you would have had an objective definition of GERD. And then if you have the added advantage of abnormal esophageal acid reflux on esophageal pH monitoring, and then you have a definitive definition of GERD. So it's actually a clinical spectrum of disease that essentially, like we said, starts off as a physiologic process and then may then become symptomatic GERD, which could be typical or atypical. and with or without esophagitis, and then it can then progress to esophagitis and then become complicated in terms of complicated esophagitis. And then looking at this slide that I picked up from YouTube, where you have the endoscopic phenotype of GORD. It extends from the non-erosive GORD and then can progress to the reflux esophagitis as well as Barrett's esophagitis. So in terms of epidemiology, it's a worldwide disease, accounting for about 5.6 million physician visits every year. In the Western world, it's up to about 20% of adults will experience at least one episode of troublesome GORD symptoms every week. In Asia, it's about 5%. And this has actually coincided with the increase in incidence of obesity. And then we'll see later on the interaction and the relationships between obesity and GORD. So in America, American population, up to about 16% will experience regurgitation symptoms. 6% will experience up to troublesome heartburn. And in terms of the economic implication, up to about 18 billion per year is spent on GORD itself and the complications thereof, of which about just a little over 12 billion every year is spent on the use of proton pump inhibitors alone. And in terms of the indirect effect on work, up to about $75 billion annually spent. Looking at this map in terms of the distribution, we see that in America, up to about 20%, the darker shades have experienced higher prevalence of GORD symptoms. America has about 20% and less so in China. And then in terms of the ethnic demographic findings, looking at this graph here, we find that in America, Houston, out of about 27% of the Black population, as well as 23% of the white population will experience weekly GORD symptoms. With less population of the Chinese experiencing these GORD symptoms. And this graph was picked up from Nigeria, where a study was done to look at the percentage of the population who experience GORD. And we can see that they have a nationwide percentage of about 7.6%. The northeastern part of that country, up to about 9.8% population experience GORD symptoms. So there's a slight male preponderance in terms of GORD, and then symptomatic women are more likely to experience the non-erosive reflux disease. And then men, when they have long-term symptoms, might end up having, or men are more likely to have erosive esophagitis, as well as also leading to Barrett's. The true prevalence of esophagitis is actually really difficult to determine, and this is because sometimes a lot of people who don't feel sick, who are well, they don't usually present themselves for endoscopy. And we know that some patients actually are asymptomatic, but they end up having esophagitis. So talking about the anatomy and the physiology of the lower esophageal sphincter, we can see that there's a lot of it that contributes to the prevention of reflux, in which we'll see later on in this presentation. You can see that there's a lot of contribution from the lower esophageal sphincter, including the internal and external muscle groups. And then there is a contribution from the phrenoesophageal ligament, and then the diaphragmatic crura on both sides also contribute to the prevention of reflux in terms of the lower esophageal sphincter. So the lower esophageal sphincter actually addresses tonically contracted, with a resting pressure of about 10 to 30 millimeters of mercury, and of which only just about 5 to 10 is needed to prevent gastroesophageal reflux. And there's usually considerable diurnal variation in that pressure. And a lot of factors contribute to to modulate the pressures of the lower esophagus. And we have hormones like gastrin and motilin, which will tend to increase the pressure, and hormones like secretin and CCK will tend to decrease the pressure. And then we also have other factors and other agents like food and other drugs, which have varying implications on the lower esophageal sphincter. So what are the basic risk factors for the development of gastroesophageal reflux disease? So the older you become, the more likely you are to experience the symptoms. And excessive body mass index in terms of obesity and increase in body weight has been shown to contribute to the development of GORD. And this is due to several things. Number one, increase intra-abdominal pressure, and adipose tissue has been shown to produce some cytokines and inflammatory cells, which then contribute to the development of esophagitis. Looking at this graph here, we can see here that the higher the BMI, the higher the incidence or the occurrence of GORD symptoms. Other things that will increase the intra-abdominal pressure, smoking, anxiety and depression, and less physical work have been implicated in the development of GORD. And then there is a controversy or there's a discussion of the involvement of genetics in the development of GORD. Looking at this data, which was produced by research that was done, we can see that there's up to about 42% concordance of the presence of reflux disease in monozygotic twins as compared to about 26% in dizygotic twins, which tend to lend credence to the important contribution of genetics to the development of gastroesophageal reflux. Spicy food have also been, the ingestion of spicy food have been discussed about as to the contribution. And then H. pylori. H. pylori infection, there's also a lot of controversy as to the contribution of H. pylori to the development of GORD. But if we look at this, series that was done, we see here that there's not much difference between patients who had undergone H. pylori eradication at 1 and at 6 months. You can see here that the presence of GORD symptoms occurred around about 15% in patients just before they were eradicated, and that increased to about 17% with patients following eradication at 1 and at 6 months, which doesn't show significant statistical significance. And so which doesn't really show that H. pylori does contribute to the development of GORD. And then looking at this study, the PRO-GORD study, which basically looked at the population characteristics of patients who had developed GORD, you can see here that patients who were older at 55 and older had some contribution, and male patients as well as patients who had increased BMI. So what is the basic pathogenesis of the development of GORD? And it is said that it is a complex imbalance between the defensive mechanisms as well as the refluxing elements of the esophagus. So this then tips the balance to the refluxing element, and then sets off a sort of a cascade of events. So the anti-refluxing barriers will include the intrinsic lower esophageal sphincter, the diaphragmatic crura, and as well as the intra-abdominal location of the lower esophageal sphincter, including the phrenoesophageal ligament. And also as well as the angle of His. We can see from the initial diagram that we put up earlier, we can see that there is a sort of a sharp angle between the esophagus in terms of the upper stomach, including the cardia, as well as the lower esophagus. You can see that there's a sharp angle between the two structures. This tend to prevent the refluxing of materials from the stomach into the lower esophagus. And then esophageal acid clearance and secondary peristalsis, all this tend to clear the lower esophagus of acid and some substances from the esophagus, including saliva production. The average individual will produce up to about 1 to 1.5 liters of saliva every day, as well as frequent swallowing. We know that everybody will swallow up to about 600 times a day, and these tend to clear the lower esophagus of refluxing substances, as well as the epithelial barrier function and the tissue resistance, which prevents the development of esophagitis. And then the refluxing elements will be, the gastric acidity, as well as the contents of the stomach, including things that are, pepsin and hydrochloric acid, as well as the volume and the frequency of the reflux rate, and also substances from the duodenum. So this graphic scheme tends to look at the various contributions of different parts of the stomach and esophagus to the development of GORD. And you can see here that there's impairment, anything that tends to impair the clearance of the lower esophagus will contribute to GORD. Hiatus hernia, the inappropriate relaxation of the lower esophageal sphincter, as well as gastric acid, pepsin, when they're raised or not, and then impaired salivary function, impaired esophageal mucosal defense, reduced pressures on the lower esophagus, and then pyloric incompetence and delayed gastric emptying. So the transient lower esophageal reflux, it's a normal phenomenon occurring several times a day, and this has been shown to contribute to the development of GORD. And hypertensive lower esophagus, like I said, hiatus hernia, impaired esophagus clearance, as well as delayed gastric emptying. So transient lower esophageal sphincter relaxation times a day, and these are quite independent of swallows, and they actually tend to persist a little bit longer than the swallow-induced lower esophageal sphincter reduction. And like I say, they are usually physiologic in nature. However, they're not always accompanied by refluxes. And then this diagram looks at the of hiatus hernia. This diagram looks at the contribution of hiatus hernia to the development of GORD. We can see that with hiatus hernia, weakening and shortening of the lower esophageal sphincter, with some rupturing of the phrenoesophageal ligament and accompanied by widening of the diaphragmatic hiatus. And then with that, there's development of the loss of intra-abdominal lower esophageal segment, with some retention of gastric fluid in the hernia sac. All these contribute to the development of GORD. So what are the symptoms of GORD? So these have been divided into typical symptoms and atypical symptoms. So the typical symptoms would be heartburn. So heartburn is described as a burning sensation from the epigastrium, which radiates towards the chest and neck, as well as the back. It's usually worse after meals and when the patients lie supine. And there's different, different models have been described, have been used to describe the contribution of heartburn in terms of symptoms. We can see here, using this model, which is quite talked about a lot, So with the refluxing of acid, pepsin, and bile fluid into the lower esophagus, this stimulates the chemoreceptors and mechanoreceptors with development of dilated intercellular spaces, and then this sensitizes the mechanoreceptors as well as weak acid sensitivity and as well as acid sensitivity, and then this is all these are processed in the brain and then leading to the development of heartburn. So the atypical symptoms would be chest pain, belching, nausea, epigastric pain, as well as bloating. And then there are some extraesophageal manifestations of GORD, which include pulmonary, including asthma, aspiration pneumonia, chronic bronchitis, and some ENT contributions like hoarseness of voice, laryngitis, as well as pharyngitis and others. So in terms of the diagnosis of GORD, looking at this schematic algorithm that I also picked up from the internet. So you have a patient who presents with either typical or atypical symptoms of GORD. You first of all want to find out if this patient experience alarm symptoms, including dysphagia, bleeding, anemia, or even weight loss. So if the patient does not have any of these alarm symptoms, then you're welcome to try the trial of PPI up to about 8 weeks. And if the patient responds, then you can then taper off the PPI. And if the patient then experiences nocturnal symptoms, you may then add H2 receptors. However, if this patient has alarm signal, then you progress to doing upper and esophageal gastroscopy. And depending on what you find, then you can then proceed from there. If the endoscopy is abnormal, then you can treat according to the findings. However, if it is normal, then you then decide to either do pH monitoring or you consider referral to ENT if the patient has extra esophageal manifestations. And depending on what you find on the pH monitoring, then you proceed from there. So trial of PPI usually helps patients with typical reflux symptoms, and you use once or twice daily PPI, 30 to 60 minutes before meals. This has been shown to have up to about 70 to 80% sensitivity, but the specificity, but the sensitivity is quite low at between 40 to 60%. It's been described to be, it is cost effective. It is more effective if the patient has abnormal acid reflux times or has developed esophagitis, but there's no evidence to increase the dose beyond the BD dosing or to use another PPI. And so then upper endoscopy, if you have to do it, has specific diagnostic evidence for GORD, and patients who have early grades C and D, or they have evidence of Barrett's esophagitis, or you've picked up a peptic stricture, can lend credence to the diagnosis of GORD. And then if you do a biopsy, you can then use the histopathology score, and then the pathologic findings of GORD on biopsy would be things like basal cell hyperplasia, intraepithelial inflammatory cells, dilated intercellular spaces, and papillary elongation. So the use of PPI trials have actually decreased the finding of reflux esophagitis on GORD. We can see here from this series that was done, up to about 90% of patients had both early grades B and A and B, which according to the diagnosis of GORD are not definitive diagnosis of GORD. And so it has quite low sensitivity, but high specificity for GORD. And this will represent the Los Angeles classification of reflux esophagitis. So once the patient has both C and D LA grades on gastroscopy, then you then diagnose GORD. And then if you have to do pH testing and pH impedance, So these have been described as the gold standard for the diagnosis of GORD, and they tend to show and pick up abnormal esophageal acid exposure. Using the pH reflux monitoring devices, you can use the catheter pH monitoring, or you can use the multi-channel pH impedance monitoring, or you can also use the wireless pH, which is called the Bravo pH monitoring, where you put in the capsule, and this can then extend, you can then extend the capsule for up to more than 24 hours, even up to 48 hours. And this is quite convenient for the patient. However, the use of it is burdened by the expensive nature, and it's not readily available everywhere. So when you use the pH testing and the pH impedance, they tell you whether GORD is present or not, and they tell you if reflux is actually the one causing the symptoms of the patient, and if there's adequate acid suppression, and then they also determine volume reflux. So to differentiate between the 24 hours pH testing as well as the pH impedance testing, so the 24 hours pH testing is usually the first technique that you use for evaluation. So if a patient has never been diagnosed with GORD, then you'd rather use the 24 hours pH testing, and the patient has to be off PPI for up to about 2 weeks. And so this essentially established whether the patient has GORD, the symptoms, the reason why the patient's got the symptoms is due to GORD. Whereas the pH impedance testing helps you to diagnose, also helps to diagnose GORD, but then you use it more if the patient has got persistent symptoms even whilst on PPI therapy. And so you can test while the patient is on PPI therapy. So what are the measurements that we use when we're measuring esophageal pH testing? So you want to look at the acid exposure time. And this is recognized as the percentage of time where the pH is less than 4. And then you also use certain modalities like the reflux association symptoms. So you want to find the association between the time the patient is developing the symptoms as well as the time the patient is having reflux. And so there's several parameters that I use. You use the symptom index, the symptom association probability. So the symptom index essentially looks at the percentage of reflux related symptom episodes, whereas the symptom association probability as well as the Gilbert probability estimate, they look at the probability of the symptoms being caused by refluxing. And then you look at the number of refluxing episodes. Normal should be less than 80. Anything more than 80 is abnormal. Sorry, normal is less than 40. Anything above 80 is abnormal. Anything between 40 and 80% is indeterminate. And you also use a Demister score. So this is a diagram again that I picked up from YouTube, where you have a demonstration of the use of pH esophageal monitoring, where you put in the probe. Usually it has proximal and distal probes, which will be at about 5 centimeters just above the lower esophageal sphincter. This will be a sort of a demonstration of the kind of results that you'll pick up when you do a catheter-based pH testing. And you can see here that you look at the acid exposure time from the upper esophageal sphincter, as well as the proximal probe, as well as the one from the distal probe. And like I said, anything less than 4% is normal. Anything above 6% is abnormal. Between 4 and 6% is indeterminate. And then the pH impedance testing uses several probes, several sensors at different levels in the probe inserted into the lower esophagus. We can see here that it looks at the different kinds of impedance using different kinds of materials, from air to food and solid materials. And so air has very high impedance, whereas solid food will have a low impedance. So impedance basically looks at the impedance of the organ wall being up to 10 times to 30%, 30 times higher than the impedance of the contents that it is transporting. So this would be the sort of results that you pick up from. Again, I picked up this diagram from the internet. So sort of results that you get from the pH impedance test. You can see here that each line here represents the different sensors at different levels, and it also has a pH sensor here, and then the impedance is seen as a sudden drop of about more than 50% in impedance will represent a positive impedance. And you can also see that the direction of this reading it shows that there is some reflux event going up, as opposed to a food bolus that will go the opposite way. You can see that it actually goes up in terms of the food, and this also coincides with the drop in pH of more than 4. And then this is the color representation of the pH impedance testing. We can see that black will represent high impedance, whereas white will represent low impedance. Black, again, from air. And you can also see here that the white areas represent the areas of low impedance, and you can also see that this goes up, representing the direction of refluxing. And this again coincides, with a lower probe, pH probe. There's a drop in pH. So in terms of diagnosing, using all these modalities, including endoscopy and pH impedance, to diagnose GORD. So when you use endoscopy with pH and pH impedance testing, when you have a conclusive evidence of pathologic reflux is when you have a combination of early grade C and D esophagitis, or you have long segment Barrett's, or you find positive peptic esophageal stricture. When you combine this with an acid exposure time of more than 6%, then you have a conclusive, definitive evidence for the diagnosis of pathologic reflux. When you have between early grades A and B esophagitis on endoscopy with acid reflux time that is not up to 6%, then you have borderline or inconclusive evidence for the diagnosis of GORD. Other supportive evidence will include the use of histopathologic score, or you find low mucosal impedance, or you find reflux symptom association, which don't necessarily, which are more than 80. When you combine these two, then you have supportive evidence for GORD. What will not diagnose GORD, or what will be against the diagnosis of pathologic reflux, will be when you have less than 4% acid exposure time, or you have reflux episodes less than 40. So how do you manage GORD? So you start with lifestyle modification. So if the patient is obese, you want them to lose weight. If the patient is consuming drugs or food that exacerbates their symptoms, you want to ask them to stay off. Although there's a bit of controversy on lifestyle modification, but you want to include this in your management plan. And then you start the patient on PPI. And then PPI plus or minus the use of H2 receptor antagonists. Looking at this diagram, so in terms of the mechanism of actions of GORD pharmacotherapy, so we know that PPIs block the proton pump by blocking the hydrogen potassium ATPase. And then the H2 receptor antagonists, they block the histamine receptors in the basal area of the cells. And then when you use antacids, they block or they neutralize secreted hydrochloric acid. Other modalities will include H2 receptors and antagonists, like I said, and the use of prokinetics is also controversial. So in terms of endoscopic therapies, you can use radiofrequency ablation, the so-called strata procedure, or you can also use transoral fundoplication, including procedures like Esofix, Muse, GORD-X, or you can use anti-reflux mucosal resection procedures. In terms of surgery, you need to have indications for proceeding to do surgical operation for the patient to treat GORD. So indications will include refractory GORDs. If you have documented GORD patients who want to stop chronic PPI despite excellent control, or you have GORD complications like Vagitis or peptic strictures, or you have patients who have heartburn, which has been eliminated by PPI, but they still have a significant volume reflux. So preoperatively, you want to do, of course, a gastroscopy to make sure that there is no other pathologies that may be contributing to pathological reflux. Of course, you want to do your manometry to rule out motility disorders and things like echalasia. We know that if your patient has echalasia and then you proceed to do surgical procedures, the complications thereof may be devastating for the patient. Of course, you want to do your 24-hour pH impedance to determine the amount of acid reflux or non-acid reflux as well. And then you may tend to use also do your barium swallow. So what are the various modalities in terms of surgical interventions for these patients? So you can do fundoplication. So fundoplication basically involves, wrapping the upper part of the stomach around the lower esophagus, and you can do this in several ways. You can wrap it around in a 360-degree fashion, the so-called Nissen fundoplication, or you can do it in, up to about 270 degrees posterior, the so-called toupee, or you can do the Dora procedure where it involves up to 180 degrees anterior. You can also do cholecystoplasty or esophagectomy. So what would be the complications of GORD? So these patients, if they're not treated or they have long-term gastroesophageal reflux, they could develop Barrett's esophagus. They could also develop peptic stricture with dysphagia. They could also have ulcers, which could also progress to peptic strictures. There could also be perforation as well as hemorrhage. So we just have a word on non-erosive gastroesophageal reflux. So the Velvis consensus definition has described NERD as a subcategory of GORD, which is characterized by troublesome reflux related symptoms in the absence of esophageal breaks or erosions at conventional endoscopy, without recent acid suppression therapy. And NERD would represent most of the patients that are in the community that will pick up. There are several subtypes of NERD. There's acid reflux related NERD, where NERD occurs as a result of increased acid refluxing, or you have the weakly acid reflux related NERD, where the NERD is as a result of weak acid producing positive symptoms. And some have described this as hypersensitive esophagus. And then you have the non-acid reflux related NERD, and then functional heartburn. Some also describe it as a subtype of NERD. So using the heartburn and you know, you have a patient who's got heartburn, but there's no history of documented GORD. So you do your endoscopy and you find that there's normal endoscopy with biopsies, and then you do your you put the patient off PP high, and then you put the patient on pH monitoring. Now, when you combine the endoscopy findings, normal endoscopy findings with the pH monitoring, then you can then describe the patient in different in categories. So when you have a patient who's got normal acid exposure with negative symptom association, then you describe this patient as having functional heartburn. So what this means is that when you do your pH monitoring, you find that that is normal, and then and that doesn't correlate with the symptoms of the patient, then that is described as functional heartburn. When you have normal acid exposure with positive association of symptomatic refluxing, then you describe those patients as having reflux hypersensitivity. And then when you have abnormal acid exposure with the positive findings, then these patients are described as having non-erosive reflux disease. So in terms of the differentiation between NERD and erosive gastritis, we find that a lot of females will present more with GORD, with NERD, as opposed to more male patients presenting with erosive gastritis. There's not much age difference between the two groups. You know, alcohol is more involved. There's actually not much difference with the use of alcohol. And then the esophageal acid clearance is more abnormal in erosive esophagitis. So the diagnosis we include the use of endoscopy, where you find normal endoscopic findings, and then you can also use your pH monitoring and impedance, which will tend to be abnormal. So you find abnormal pH impedance, which normal endoscopy, then you say these patients have got a NERD. The treatment, again, is like GORD, where you use your PP high, and there are some other novel therapeutic modalities. Talking about functional heartburn, the Rome-4 diagnostic criteria describes these as having burning retrosternal discomfort or pain with no symptomatic relief despite the use of anti-secretory therapy, as well as the absence of evidence that gastroesophageal reflux or eosinophilic esophagitis is the cause of the symptoms. And of course, you want to make sure that there is absence of major esophageal motor disorders, things like your achalasia or your EGJ outflow abnormalities, like things like your diffuse esophageal spasm, Jack-Hammer esophagus. So you need to have this criteria fulfilled for at least 3 months with symptoms onset up to about 6 months prior to the diagnosis, with frequency of at least twice per week. And then when you do your pH impedance, you find elevated acid exposure time or symptomatic or abnormal. So there's no correlation between the symptoms, symptom reflux and the development of symptoms. So in terms of the clinical characteristics of these patients with functional heartburn, they usually more common in women than men, usually middle-aged women with a long-term history of heartburn. They have, the symptoms are quite similar to those of other GORD phenotypes. And then sometimes they may have associated esophageal dysmotility. And then a lot of these patients usually have psychological comorbidities, including depression, anxiety, and somatization. So in terms of diagnosis, you need the history because you're not going to find much on endoscopy and pH testing. In terms of pH testing, you won't find it's in terms of symptom correlation with reflux. So in terms of treatment of functional heartburn, because you don't have these patients will not necessarily respond to PPI. So you want to treat them using things like your tricyclic antidepressants, things like your SSRIs or your SNRIs, including your 5-HT antagonists. Thank you.
Thank you, Joseph. I think it was a nice overview. I only have one question from the group, but I will maybe start asking, just making a few comments and also maybe asking one or two questions for clarification. So the first in your introduction, you gave a nice overview about Western countries and their role, not the incidence rates in those countries. So you've only mentioned Nigeria, a study done in Nigeria that quoted like a 7%. And I would encourage maybe not just you, but everybody else that presents on this platform, maybe to look at what is the sub-Saharan African incidences of diseases and look for them specifically. In the study that you showed from Houston, there was a higher incidence of Blacks having reflux compared to white like US citizens. I don't think that's a generalized trend, and it's something that we need to elucidate, especially in the areas that we are going to work. So that is just maybe just like a comment on that. So and that's for everybody else. What I maybe want to drill down on is the current indications of reflux or anti-reflux surgery. You just wrote surgery, and then you wrote a few things and the types of surgery that could be performed. And I take issue, and if you maybe want to go back to that, I take issue with some of the indications that you've mentioned there. You want to maybe share that with us again so we can, maybe everybody can see that again? So one of the indications you listed was refractory GORD. In 2022, do you still think that is a valid reason to do anti-reflux surgery? If you can go back to that slide, I don't know. Are you trying to get on?
I'm not sure if you can see my slides now. I just want to see if I can share my slides.
You can share again, and we can just maybe go through it briefly. We have a bit of time. Yeah, that's the one. So you said refractory GORD is an indication for surgery, and I would disagree with you completely on this, because we know that patients with refractory GORD don't do well with anti-reflux surgery or any surgery for that matter. Complications of GORD, a peptic stricture, we would not necessarily, surgery will not be the first line of treatment. There's lots of other avenues that we will take before we get to that. And even Barrett's esophagus currently is not an indication, because you're not going to stop the Barrett's by offering them anti-reflux surgery. Would you, however, say, if we look at indications, what would be the 2 prime indications in 2022 that will be the real indications for anti-reflux surgery? There's only 2.
So as much as I can see most from what I looked at, I think majorly when patients have, they have, documented GORDs and they actually want to stop PPI therapy. So they probably tired of taking PPIs,
Yes.
so they.
So could you frame that better for me? Could you say it in a better way? Who will you then offer in the clinic? What patient will you offer the chance of surgery when they say, doctor, I don't want to take these pills anymore? So it will be someone that has responded well to PPI therapy and is young. If they are 50, 60, there's no real point because the complication rate of the op is so high that we don't generally offer them at an older age. So because if they're young, they're going to have to take the PPI for a much longer period. So that's the reasoning, right? The other only indication is volume reflux. So all these other complications we deal with medically, and we don't offer them surgery as, only if it really becomes a serious problem. Not even peptic strictures these days we offer surgery to. Would you offer anybody with a hiatus hernia anti-reflux surgery? Would that be one of the things that you would consider in the clinic and say, you've got a hernia, you've got this reflux, would you do that?
I think I would, yeah.
You think you would?
I think I would, yes.
Hiatus hernia per se is not an indication for anti-reflux. So let's just be clear. It's only patients with volume reflux, whether they have a hernia or not. If they are controlled on PPI therapy and they do well on it, don't want to stop it. Okay, so that's the first thing that I wanted to address. The second thing I'd like to talk to you about is H. pylori. Now, H. pylori in Africa involves about 80 to 90% of the population. It's quite endemic. It's quite an endemic organism. In the West, it's about 20%. Maybe with a push, it will be 30%. So we can't sort of transpose Western data on our African patients as it is. So there are many, more mature is probably the right word, gastroenterologists that I know that will give you a hard time in an exam about H. pylori, eradication, and exacerbation of reflux symptoms. Now, lots of studies have since come out that it has refuted it, but I think you should know the pathogenesis. You should know the mechanism of how H. pylori could possibly worsen reflux. And from what you told us there, you gave us one slide with the incidences. I think it was it before or after treatment, after H. pylori eradication, I'm not sure. But I think you need a more holistic approach to this because you're going to be the one as the gastroenterologist that will make that recommendation. So people will ask you, so doctor, do you think I have this H. pylori? Should I rather have it treated or shall I just have it left? And you have to defend both sides of the coin. And it's not a discussion for today. I'm sure H. pylori will still come up at some point. The areas of the gastric mucosa that H. pylori affect, where the injury is, where the atrophic gastritis is. So eventually with chronic and atrophic gastritis that it continues to make, you will make less acid. So if you make that better, you will have more acid. So that's the thinking, but it's not the whole story. So I think for you and for everybody else that's watching, you have to know, if you're going to be asked anything in an exam about H. pylori and reflux, that will be that. You won't be asked all these other things that we discussed briefly. So you mentioned trial of therapy in otherwise healthy patients who don't have alarm symptoms, right? But you also said it could be once a daily dose or it could be twice a daily dose. Do you want to commit yourself to anyone in specific terms? Would you want to commit to a specific dosing regimen? And for how long are you going to give it before you decide? That's my question.
I would say BD dosing for 8 weeks.
Yeah, it is BD dosing, but it is for 12 weeks. So before you bring the patient back and then decide, they have to have that duration of treatment to assess durability of, or whether the symptoms resolve or whether they don't resolve. So just make sure on the numbers again that you know exactly where we are. Yeah, so what were the other things? On your slides had that functional heartburn, reflux hypersensitivity, and non-erosive reflux disease, and you gave a definition of that. I thought that was quite good, and it made clear what those categories are. And with functional heartburn, you say you will treat with TCAs, you will treat with SSRIs, etc., etc. What is your stepwise approach to functional heartburn, or what should it be?
So in terms of functional heartburn, so you want to establish a diagnosis. So you want to take your history, proper history, do your endoscopy, as well as do your pH impedance testing.
No, you've already diagnosed it, right? You said functional heartburn, that's my diagnosis. So okay. Now, so you're gonna start with PPI therapy. So presumably once a day dosing, right?
Yes.
So the patient comes back and tells you, no, this doesn't work for me. No, wow.
Sorry, say that again. I didn't.
So you say, so you start the patient on PPI therapy once daily dosing, maximum dose once a day, and they say, no, come back in a month or 2 or 3, and they say, but doctor, this stuff you gave me doesn't work. What is your next step? So that it is clear what our stepwise approach should be when we treat these patients. Okay.
Okay. So my next step, following would then I will make sure that the patient is taking the medication. I want to establish compliance. I want to establish, if the patient is taking the adequate dosing, and if they're taking it, if they're taking their PP highs the way they should, if they're taking it before.
Good. That's right.
Then I also want to establish if they have any psychological, psychosomatic or psychological issues which may be contributing to their symptoms. If they have, then I will address that accordingly. Yeah. Then afterwards, if they're still having symptoms, then I will proceed to starting them on tricyclic antidepressants. I give them daily dosing. Usually it's Nocte, and then I give them for up to about 6 to 8 weeks. Then I'll then bring them back because these TCAs and SSRIs, they take a while to start to work and to establish. So give them a bit of a while. Yeah. Bring them back again and review, and then accordingly, then I'll probably if I start with one agent, if they don't respond, then I can switch to another agent, and I keep bringing them back. And all the while, I'm looking at compliance, looking at if there are any other psychological issues going on, and then I'll address accordingly.
Yeah, so that's the important point here. The important point is you start with single day dosing. You may opt to give double dose if you feel they are not just adequately controlled at nighttime. And if they still don't settle on that, then you start adding the other things one by one, reviewing and that's an important concept because, sometimes we see these patients come back all the time and they're not doing completely well. What are you going to treat the reflux hypersensitivity with and how?
Reflux hypersensitivity, I will treat them with PPIs.
And if they don't respond?
I'm not so sure. I'll just have to look that up.
Okay. So what, you know, the diagnosis tells you that they have a hypersensitive esophagus. So even if you give them double dose, if they don't respond, you can give them a tricyclic antidepressant, and that should just take the edge off, as you said, at nighttime. And with all these things, you start off low with a 10 milligram at night until you reach, you know, whatever plateau you want to reach to. But you must also inform the patient that these drugs have side effects, which I'm sure you know what they all are. You know the side effects of tricyclics, and all. Let's not discuss that. I think that's and non-erosive reflux disease. What are you going to do with those? You know, we know they have reflux.
They also should get PPIs. PPIs are usually the mainstay of treatment of non-erosive reflux disease.
Yeah, let's just see how many questions are there. Those are just primarily my issues. Well, maybe in your reading, did you come across the fact that some PPIs may be better than others for reflux disease, or is it much of a muchness?
Okay, so most people say that the PPIs are usually equal, but they say that the one that is more effective in terms of refluxing will be the esomeprazole, the isomers of omeprazole. So usually the esomeprazole has been shown to be slightly better than the other PPIs.
Okay, that was the only question that I see on the chat. Well, there's another question. Is there any clear objective definition of volume reflux?
I'm not sure. I didn't come across a clear definition of volume reflux, but I think that you can define that in terms of the acid exposure time, and then combining that with the amount of reflux episodes in 24 hours. So if it's more than 80, then that will be definitive. And then if you have an acid exposure time more than 6% of the time, then that will lend credence to the diagnosis or the definition of volume reflux. I didn't really come across much.
Yeah, you must just be wary, because volume reflux is actually anything but acid. Often, because you take care of the acid reflux with PPI therapy, and then you will test them. You'll do impedance testing on therapy, right? So the other question is, how long are we supposed to prescribe PPIs for reflux disease? What do you say to that?
Okay, so I would say that it depends on the phenotype or the category of what patients you are treating. So one, if the patient is you don't take PPIs indefinitely. So if the patient has been if the patient has GORD and they're responding to you make a definitive diagnosis of GORD, and then you start them on PPI. So you use them as an on-demand basis, and then so when they have reflux symptoms, you start them on PPIs, and then when they get better, then you can stop. And then when they have other symptoms, then you start them again. So you don't specifically treat them indefinitely on PPIs, I would say.
And Cecilia wants to know, when would you consider baclofen as a second agent? You know baclofen?
Yeah, so baclofen is an agent that I'm just trying to remember the way it's described, but it's in the same category as things like your TCAs. So you can also use them for patients who have functional heartburn.
No, it's not like TCA. It increases the lower source of the tone in the LES. Okay. Yeah. So sometimes it helps to make the symptoms of GERD better. Is that something that you've seen used in your clinic? Is it something that you would consider? Is it?
Yeah, I've not seen it used frequently, but it's been described that it can be used, yeah.
So the final question here is, thanks all. Big topic with lots of discussion. Happy Valentine's. So I just want to finish off by thanking you, Joseph. It was nice. It was thought-provoking. It was really interesting. And you know, as time goes on, I'm sure we will, you know, get better perspectives of these huge topics that we discuss, and continue reading. This material will be available on the Gastro Foundation website within the next week or 2 or 3. And finally, I just want to say thank you to you as presenting the topic, and thanks to Gastro Foundation for making this possible. Thanks everyone, and have a nice or happy Valentine's Day for those of you who still go out and having dinner. Any questions, thoughts, or are we done? Cheers.
Thanks, everyone.